I'm going to hand it off to my partner, colleague, and friend, Aaron Fischman, who's in the lab right now. He's in room one.
All right. Well, welcome to Mount Sinai. Welcome to room one. It's really an incredible honor and privilege to be able to present this case.
Hey everyone, good morning. Today we're going to present a case of transradial prostate artery embolization using glue, n-BCA. So we have a 72-year-old male with symptomatic BPH. His LUTs include frequency, intermittent nocturia, 1 to 2 times every other night, incomplete emptying, urgency, intermittency, and also he has weak stream. In addition, patient reports he has erectile dysfunction. He's failed medical management in the past. Most recently, he's been on oxybutynin for overactive bladder, but has had no improvement, so discontinued. He's seeking minimally invasive, non-surgical treatment for his urinary symptoms as it's affecting his daily life and his ability to enjoy traveling. Right? His IPSS score is 18, that puts him in the moderate range. His QOL score is 5, making him unhappy. SHIM score of 2, severe ED. PSA last year was 3.1. In-office uroflow, Qmax was 10 mils per second, and his post-void was about 30 cc's. Past medical history includes hypertension, hyperlipidemia, GERD, BPH, surgical history of VP shunt, hernia repair, sigmoid resection. These are his medications. He has an allergy to naproxen. We got a CTA of the pelvis as our non-invasive imaging, and that demonstrates a prostate volume of approximately 105 cc's. His intravesical prostatic protrusion measures about 10 millimeters, which puts him up to grade 3 severe. We also noticed on the non-invasive imaging that he has variant anatomy. He has a left-sided corona mortis that's arising from the deep inferior epigastric artery, noted there by the arrow. The MIPS, the coronal MIPS demonstrate minimal tortuosity of the iliac arteries, which makes him a pretty good candidate for radial access. We also did a couple MIP reconstructions in like 30-degree LAO, RAO, to see, the branching pattern of the internal iliacs. It's kind of tough to say for him exactly where the origin of prostate comes off of, but we think maybe on one side it might be a type 4. We'll see, introp. So assessment and plan. This is a 72-year-old male with symptomatic BPH. Treatment options for him are going to be medical management, prostate, or I guess medical management, which he's already failed, prostate artery embolization, TURP, aquablation, urolift, resume, whole lip, and prostatectomy. His gland size is, about 105 cc's, which is above the standard for urolift and resume. And the patient prefers minimally invasive, non-surgical treatment. So we're here today doing a transradial prostate artery embolization. In regards to the equipment details, we're doing radial access. So we're going to use a radial cocktail, including of heparin, verapamil, and nitroglycerin. We're using a slender 5 French glide sheath in the wrist, left radial artery, and our base catheter is a 5 French by 130 centimeter Neuron Select Bernstein catheter. And through that, we have a Benson wire. In regards to the microcatheters, there's several options out there. We typically use 2.2 French Sniper balloon occlusion microcath, but we've used ProGreat Lambda or the 2 French True Select. And then in regards to microwires, typically we start off with the 016 Fathom wire. If we do encounter some complex anatomy, then we'll bring out the 016 Acai Meister wire. Our embolic of choice is going to be 1 to 10 n-BCA to Lepidol mixture. And in regards to discussion, the IPP, we published a case, I guess a report, sorry, in 2020 that discussed outcomes of prostate artery embolization between patients who've had severe, which is greater than 10 millimeters of IPP, and non-severe, which is less than 10 millimeters of IPP. And we found that there was no significant differences in early outcomes of patients who underwent PAE with severe versus non-severe intravesical prostatic protrusion. And then there's a lot of studies out there that kind of discuss the use of n-BCA in prostate artery embolization. Majority of them show that, it's a safe and effective alternative. There are some studies that also demonstrate that there's lower fluoro use and also shorter procedure times. Thank you.
All right. Well, thank you, Puneet. Just want to show you where we are right now. Can you guys zoom in on the wrist a little bit? Okay. So we have the arm tucked very close to the side. This is our standard approach for radial access, as you guys can see here. This is a 5 French slender, as Puneet mentioned. We usually access a little bit higher on the wrist, approximately about that much higher than the styloid process, which gives us ample space to be able to get our diagnostic catheter pretty close to the prostate artery, which, as you'll see in a few minutes, that's one of the key things, in my view, to getting very close and getting a quick cannulation of the prostate artery. This diagnostic catheter that we have in here is 130 centimeter penumbra burn tip. And this is a nice catheter, 040 lumen. But what I like about this for radial access is it's 130 centimeters. So this gives us a few extra centimeters to get to the target vessel. We're actually hooked up to the power injector right now, but we haven't done the angio yet. But I'm going to go back to the fluoro and show you what we did so far. We came down the arm. We used a Benson wire, and we didn't get the wire to go immediately into the arch. So we did an angiogram, and he does have some vascular disease. So we switched to a glide wire here, and we were able to cannulate the ascending aorta pretty easily. You can see the calcification on the aorta here. And so when we see that, we often will switch very quickly to a Simmons catheter. We usually use a Simmons 1. So in that scenario, we put down an exchange wire. In this case, we used a Benson wire. And we form our Simmons in the heart, as you can see here. Once it forms, then we basically just pull it back and we cannulate the descending aorta, advance our long wire, usually a Benson, and then we switch out for our diagnostic catheter, which in this case is the 130 Berenstein. So we came down very easily. We did a quick angio here showing the bifurcation. And the way we visualize the bifurcation is typically contralateral from the side that we're on. So we're currently on the left side of the patient. This is the left common and internal external iliac arteries here. When we set up the angio, we typically use the contralateral to open up that origin. And that's where we are right now. So we cannulated the internal iliac. We're going to set up an angio here. We're all set up to do that. We're going to go 4 for 20, typically in the internal iliac, and we're going to see what type of origin we have in the prostate. So we're going to step out for 1 sec. And then if you guys have any questions, this would be a good time to start asking.
Awesome. Good. So I want to ask just quickly because, it looked like a little bit of work to get down. What kind of floor time are you looking at right now? And, I think probably people wonder, why are you even going radial? If you want to touch on that really quickly.
We go a little reflux there. We're at 4 minutes of fluoro time. That's good. So I'm going to walk back into the room and we're going to just put up the images while we talk. 4 minutes of fluoro time. And really it was just that getting down the arch with the Simmons that took a few extra minutes of fluoro time. But other than that, I think radial access is a lot easier to cannulate some of these difficult origins. And this is exactly what we saw on the CT, by the way. It's what it looks like. But I think radial access gives us the best chance, in most cases, not every case, to get very close to the prostate origin. Sometimes it's hard to do that with a femoral approach. And so it's sort of an interesting concept because a lot of people, when they do these cases, they'll leave their base catheter almost too high, in my view. And I'd rather be able to torque the catheter almost as close to the prostate origin as possible.
I'll tell you in a second.
So this is interesting. What do you guys think of this angiogram? I'm going to go back to this image here. The first thing that we notice, and we knew this from the CTA, which is another reason why the CTA is so valuable, is that we have no obturator artery here. So given that that's the case, it makes it a lot easier to visualize the anatomy. And so Puneet was showing me before how to do this. I'm going to go pull up processing, and I'm going to zoom in here. I'm going to start drawing on the screen. This is our new Phillips room, so you can do all this fancy stuff here. This is the SVA right here, as we all can see, right? How do I zoom out? There we go. And we don't see the obturator. As we come down, we see the inferior glute here, and we see the pudendal. And if you look closely, it looks like the prostate artery, which is this vessel here, we're going to trace it all the way back, originates off the side of the pudendal, which is right here. At least that's what I think based on this image. Do we all agree?
Definitely.
So this is a classic
Yeah.
type 4 origin, although it's a little angulated. So, before we cannulate these, what I like to think about is which microcatheter would give us the best chance of cannulating this, which wire. And then obviously we want to, if we're using n-BCA, we want to try to use, I like to try to use balloon occlusion whenever possible. It gives us a much deeper penetration, which we can talk about in a few minutes. The other thing that we're going to try to do, which we can do right now, is push the base catheter a little closer to the pudendal. We could probably almost even cannulate the pudendal with the base catheter. I don't really have an issue cannulating these vessels, particularly the pudendal and the obturator with a base catheter. We could probably remove those marks, my John Madden marks there.
There we go.
So one of the things that I like to do is use this base catheter without a wire sometimes, and I'm just going to push it a little bit closer.
So Puneet
And
had
now
a
that
great
we,
slide. Sorry, Aaron. I
Yeah.
was going to say
No,
Puneet
go
had a
ahead.
great slide showing the escalation approach. So you're looking at this angio, and are you thinking that balloon occlusion is? Are you still thinking that that's the way to go, or are you
Yeah.
concerned that you may not be able to track it into that very tortuous prostatic
You
origin?
turn coupling off, Debbie. I think we can get it in, no problem. So we're going to use the sniper, I think, to start on this side. And what's interesting about that CTA is it didn't show in detail, but it did show this origin. If you go back and look at it. So I'm not surprised that we have a type 4 here.
Aaron, do you insist?
Do you see the origin there? I mean, it looks like it might be in a different spot. I obliqued it a little bit more.
Yeah, it might be coming off the inferior glute.
Inferior glute. Yeah.
Yeah. So maybe it's not. I was a little surprised that it was coming off that portion of the pudendal, which is not typically what we see. So you're right. I think it is coming off the glute. So that would make this a type 5 origin, not a type 4, if that's the case. So we prepped
did you mention your
the
obliquity
sniper.
for these views? I don't know.
Yeah.
if,
So Puneet
the
mentioned this
audience-
earlier. He said 30 degrees as a place to start. This is a 45. Actually, no, this is a
49.
49. So we obliqued it more.
and you have
And
that
so I'll
10
usually start with 30.
cranial.
10 cranial.
Yeah, I think the majority of us are doing some 35 to 45 IPSI oblique on the side that we end up in, and with a 10 cranial, like you said.
You insist on a CTA for every patient that you see in the office?
It's not a requirement, Jay, but I think it's really helpful, for lots of reasons. We can keep going.
Yeah.
In terms of patient selection, do you have a size and cut up minimum for volume-wise for the prostate?
Well, that's an interesting question. That's a completely separate question.
Yeah.
Look, smaller prostates are much harder to embolize, as we all know. Plus, they're not going to get the same volume reduction and potentially the same response. And so, the smaller the prostate, the harder it is, and I think the less likely you're going to get a dramatic improvement. It doesn't mean that you can't get it. It just makes it a lot more challenging. So there is no real cutoff, Jay, but I think, once you get below 40, it becomes really, really hard.
Yeah, I mean, I think that just to unpack it one step at a time, the CTA is definitely going to show you lots of good information. It's going to show you that process if you don't have an ultrasound or anything like that. It's going to show you bifurcation. It's going to show you corona mortis. It's going to give you a lot of information. And if it gives you more things like other pathology, bladder pathology, it's going to give you a lot of information. So I don't think it's a requirement, but I think it's incredibly helpful in kind of working up the patient in the office.
So I'm noticing you're not using a TUI. You want to comment on that?
No, I don't like the TUIs anymore for prostates because I like to be able to move the microcatheter and remove it quickly, as you see when we do glue. So I stopped using them for these cases. So the other thing that we're going to do, Puneet's going to put the wire all the way down the inferior glute. Oh, actually, sorry, he already got in.
Yeah.
So we're going to just go with it. All right. So once we get a fair amount of wire, the other thing, we can do it now. I'm going to take the base catheter and bring it down a little bit without losing our access, just to give it a little bit more stability. And so now that we have a fair amount of wire into the prostate artery, I'm going to just sort of try to get this to go as smooth as possible. And it tracked pretty well. So now that we're in the prostate artery, or what we think is the prostate artery, we're going to go back to a little less oblique, and we're going to center a little bit lower. We're going to take this wire out, and we're going to do an angio and see where we're at. Any other questions on your end, guys? There's probably a lot, I would imagine.
I mean, in terms of talking about the radial access that we were doing, I think we ran into the situation where there was a little bit of tortuosity in the arch, and we quickly kind of troubleshooted with something that we're familiar with. And I think it just comes down to, you're good at navigating things that you do a lot of. So if you're not familiar, you might, poke around for a while, but because we have experience with it, 6 minutes into this, we're in the prostate artery. And I think, just like we have ways of, troubleshooting a difficult arch, if we were femoral, it's just one of those things that as you get facile with it, it just becomes kind of more second nature.
So just to give you guys an update, we're going to pull back a little bit. I just gave a little puff there. Yeah, there we go. We're at 7 minutes of fluoro time.
Yeah.
So this is the first angio. So we have a couple things here that are interesting. I think that vessel that we were in a little bit too deep was probably a rectal branch, if I had to guess. And the other thing that we see here is a fair amount of spasm. Even though this is a small catheter, it's actually a very small vessel. So we're going to give some nitro. We are very liberal with our vasodilators when we do prostate embolization. We're going to give about 250 cc's of nitro right now, and then we're going to follow that with verapamil. One of the interesting things about using these medications, and I like to call this the poor man's cone beam CT, is the patient will tell you what vessel you're in when you deliver these. So typically, if you're in the prostate artery, they feel it in their penis. So that's number one. And if you're in the rectal branch, they'll feel it in their anus. And then obviously, if you're in other branches, they'll tell you what vascular territory it is. So it's a really good way to find out what vessel you're in if you don't have access to cone beam CT.
So in this scenario, would you try to go distal to the rectal artery, or how would you manage that?
So we're gonna give the vasodilators. We're gonna repeat the angio. Before we go distal, I like to give the vasodilators. I think it's going to give us the best chance of success here. So that was the verapamil we just gave. We're going to flush and we're going to repeat the angio. Yes, but I agree with you, Viv. We should go distal. You can see that prostate artery pretty well here, and you can see the middle lobe pretty well too. We'll get a better picture. But if you look closely at this angio, you'll see these little spidery branches that are going north. That's the median lobe vascular supply. And so we really want to try to get embolic into that spot, but we'll see. Okay.
I think you're seeing like nice periurethral supply too, and even some cross filling to the other side.
Yes.
Maybe we can
So here's our
backtrack a
next
little bit
angio.
and just talk about sort of, the in-office discussion. You mentioned a lot of alternative treatments that patients may be asking about. How do you counsel your patients in the office?
We're going to go more distal. Let's grab
Yeah.
that wire.
Okay.
Well, you want to be able to talk to them about all the different options. And so, PA is a great option for this patient, but not for everybody, obviously. We go over all the alternatives. His prostate's a little bit big for TURP, but there are people that would TURP this. Resume, and we put that up as a roadmap.
Oh, we did. We gave.
Resume and Urolift are much more popular these days, as everybody knows. But the most of the studies that have been done on those treatments are with prostates below 90 grams, and so he's a little bit big for that. HoLEP is obviously a good option for large prostates, but there's not a lot of operators around the country that do HoLEP. Prostatectomy is not a common procedure done for BPH these days, but obviously that's an option too. And then aquablation is a new therapy that not as size limited as Urolift and Resume. But some of the early studies that looked at aquablation had a fair amount of bleeding in large prostates. And so there are some people around the country that are using PAE prior to aquablation, sometimes prior to TURP, and even sometimes prior to HoLEP, and people who are at high risk for bleeding. It looks like that's not the vessel we want to go into, right? So what we're going to do, we're going to pull this back a little bit. There we go.
Yeah, there we go.
Yeah, we're going to try to make that turn. Usually we try to make the turn with the wire. There we go. Before we actually bring down, because this catheter is a little bit stiff, and so you want to just make sure that you get it. That's a good spot right
Lovely.
there. I like that. So we're in a good spot, I think, to probably start embolization. And again, 8 minutes, and
what's a good spot for embolization?
well, we want to be as deep as we think we can get. I mean, we don't want to go too far. If you go back to the old, we're going to do one more angio, then we'll throw it up. The old perfected technique that Carnevale demonstrated. You do proximal first and then distal, but that really only applies to particles. It's not as relevant when you're using a balloon and/or liquid embolic. And so this is another reason why we like this, because it can actually get a proximal and a distal embolization with one injection. But you guys tell me if you like this spot. Would you guys go more distal? Maybe a little bit, actually.
Maybe a little bit.
Yeah, let's go a little bit more distal, just around that bend.
Were you originally using cone beam CT in these scenarios and you come away from it?
Well, cone beam CT is really used, I think, for 3. You could put that up, Debbie, as a roadmap. Cone beam CT is probably useful in 3 scenarios. Number 1, looking for the prostate artery using an embolization guidance or something along those lines. So that's one. The second reason is potentially to look for collaterals and other feeders. And so we often get distracted by the main prostate artery. We forget about collaterals. There's often multiple pedicles that feed the blood supply to the prostate, in particular the pudendal below and the superior vesicular above. So in those scenarios, the cone beam CT with embolization guidance can actually show you all the feeders at once. But there are angiographic signs that allow you to do that without potentially needing to do that. And then the last reason we do cone beam CT is to look at the coverage of the gland after embolization, which we may actually do today to show what that looks like for everybody as a demonstration.
How do you feel
So
about
I think that looks good.
That
What do
looks
you
pretty
think?
good.
I mean, we don't want to go too far in here, but we want to be able to get a good deep penetration without without worrying
Just
about
pull
too
that
much
out.
non-target.
We have a question
I mean,
from
we
the
always have the
audience.
option of giving a little bit more nitro, a little bit more verapamil, depending on
Yeah,
what
let
we
me give
see.
it more nitro. Go ahead.
It's kind of going back to your approach from a radial access in terms of screening for disease in the arch. How or do you do that, and does that impact your consideration for access?
Well, it does. I mean, you want to be able to do these safely, and if you have too much disease in the arch, it's generally not considered a good candidate for radial access. Occlusions are generally bad, subclavian occlusions, aortic stenoses, dissections, but sometimes dissections are easier to deal with from a radial approach than from a femoral approach, but it really just depends on the patient.
I mean, I think from a practical perspective, I don't think any of us are routinely screening folks coming in by imaging the chest.
When we do the CTAs ahead of time, unless they've had a CTA already, let's see, that looks pretty good, guys.
Yeah.
That's great.
Yeah.
Fantastic.
Okay. So we're
So when
gonna
you're
we're
doing
gonna
your
switch over to the
CTAs,
other
you're
table.
doing-
Let's switch over to the embolic table so I can show everybody how we mix up the embolic. Okay. So right here we have our glue table. We set this up separate from our main table because we don't want any saline or blood. We typically change our gloves too to make sure that there's no blood here. In this shot glass, I have 1 cc of n-BCA. This is 10 cc's of oil, Lipiodol. So we're going to basically make it 10-1. So I like to keep it 10-1. It just makes it easier. It's easier math. Let's put it that way. In groups of 10. That's just the way my brain works. So we mix it up. And that's it. That's our embolic. And so I'm going to take 1 cc aliquots. I'm going to lay them over here. I'm going to try to make sure that we keep this separate. We don't want to contaminate this with any blood or saline. I think this is probably enough to start with. We're not going to use all of this. And then in this bowl, we have our D5 water, which we're going to use as flushes. And there's lots of ways to inject glue, and people that do glue embolization in other territories know this. You could use an aliquot method, or you can just use a push method, which is generally what we do with PAE because we don't want to take too much time switching syringes because we don't have more than a couple seconds before we form a plug. The next thing we're going to do is we're going to go back over to the balloon microcatheter, and we're going to locate our little tiny syringe. If you guys can look over here, we have this syringe, which is the inflation syringe for the balloon. And so we're going to do this live. We're going to watch. We're going to inflate this balloon, and we're going to try not to inflate it too much because we don't want to pop it. We don't want to damage the vessel. So this is something you want to do under fluoroscopy.
Aaron, can you talk about volumes and the mix of contrast in there and everything?
Yeah, so this is 50-50. You want to put, as with any balloon prep, you want to just use 50-50 if possible. And I just like to zoom in a little bit just to watch. There it is. That's probably all we need, right, guys?
Yeah.
The other thing that you really want to do when you inflate a balloon in a vessel and you've changed the pressure downstream is to repeat the angio. Here, let's use a 3.
Aaron, can you talk about the benefits of using a balloon occlusion catheter?
Yeah, we might actually be able to see the difference if the anatomy on their side is difficult, but basically, let's see here. That looks pretty good. I mean, I'm very happy with that. I'm not worried about any non-target here. One of the reasons that we use the balloon, there's lots of reasons. One is that we can reverse flow in pudendal collaterals, which we don't see here, but we could potentially do that. Number two is to prevent reflux. And then number three would be to get deeper penetration. And so one of the downsides of glue is that sometimes you get more of a proximal embolization, not as distal as you would like. I think we can get pretty distal now with this case. So I think we're going to do the embolization from here, but we'll see. The balloon will definitely help us get more distal in this vessel to get a much more, I think, hopefully a more durable result. So we usually do this with two people, one person controlling the balloon and one person doing the injection. Right. So I'm going to take this deflation syringe and I'm going to connect this, even though the balloon is locked, I'm going to connect it with negative suction. So what's going to happen is once we're ready to pull this balloon out, when we're done with the injection, I'm going to flip the switch. We're going to deflate the balloon and we're going to try not to drag any glue back into the base vessel, right? That's what we're going to try to do here.
This is D5.
All right, so Puneet's going to flush the catheter with D5, 3 cc's. And I know we're going pretty fast here. We're going to have lots of time for discussion as we go to the other side, but we wanted to start and show you guys how we do this on one side, and then we can keep talking. This is really the only part of the procedure that I think is, a little bit nerve-wracking because, you never know completely where the glue is going to go. But we've done this a lot, and so
slightly bigger view there.
We feel pretty good about this location. So the key thing when you inject glue, and Puneet's done probably about 50 of these, is to go with the balloon. You don't have to go as fast, but you generally have to watch both above and below as you inject. And we're going to fluorosave this, Debbie, when you get a chance. Go a little bit faster here. So it's going through that other branch there, which is probably a pudendal or a maybe a seminal vesicle branch. But see, he stopped injecting, and what we're seeing is the median lobe completely filled, and then we also see flow down through the collateral there that's going to the penis. And so we're going to let that sort of solidify because we want that to form basically a plug. And so one of the advantages of glue, as you guys can see, is that we can fill those non-target collaterals, but not worry about small beads going distal.
Yeah, I think that's a really nice example of how with a particle, when you're injecting it, you're not going to be able to control it like this. You're not going to be able to control the flow. And even from the outset, once we were in the prostate, we're able to inject the vasodilators. We're able to put up the balloon to create a negative pressure system. We have an enormous amount of control here that you just don't have with a particle. You can pre-modify, again, with vasodilators, with where you're injecting from. But this is such a nice example of the control that you have with glue.
So I just took the balloon down, so now we have forward flow, but the vessel's probably occluded at this point. And that's it. The other thing we could do is we could just drop a little bit of glue here just to form a little proximal plug, just a tiny bit, very slow. That's it.
And then the other thing that we're seeing here is the amount of time that you have. A lot of people inject the glue and they're going to just, rip the catheter out. I mean, it really shows that with this mix, you have time to really, be patient and be thoughtful about how you're doing the embolization.
So that we're really happy with the way that went, and for two reasons. One is because we occluded that collateral, then you could see the pulsation from the pudendal going up. And so we were able to occlude that to prevent, potentially to prevent recurrence. And we also filled the middle lobe dramatically. I'm really happy with that as well. So that was a pretty quick injection. It took about 30 seconds because we waited, but that's really the advantage of using glue. We're at 10 minutes, 10.8 minutes of fluoro time, and we're halfway done.
Yeah, that's just a huge improvement in terms of the time
3 cc
that it took. I mean, you can't compare that with particles.
No, we've all done those cases, and it's much faster.
Regarding instances where you might not give nitro obviously pretty liberally. So any instances where you would not give nitro, any medical comorbidities?
Not really. I mean, some people are allergic. I've seen in rare cases you can have a seizure from verapamil. We've seen that once. But no, the answer is no.
And you see that rectal branch beautifully preserved.
Yeah, and that's definitely rectal. I mean, if we were concerned, we could do a cone beam CT, but we know based on its anatomic appearance that that's a rectal branch. And now it's more prominent, obviously, because we occluded the prostate artery, which was a shared origin. A couple other things to notice on this angio. The pudendal and the dorsal penile artery are extremely well preserved. You see the cavernosal blush from the pudendal artery as well. And we actually didn't take out the rectal, which we probably could have, at least as we injected glue and pulled back, we probably could have taken out that rectal proximally, but we didn't need to in this case because we were so distal in that vessel. And so that's about as good as we could probably
Yeah,
expect
that's a
that side to
fantastic
go.
result.
That's a perfect result.
The other thing to keep in mind is the obturator. We probably won't check the obturator on this side because we have full coverage of the prostate. So we're going to go to the right side now.
And just to highlight, the collateral that we saw, the control that we had, there's a conversation now where we're at a place with prostates where it's, retreatment, recurrence. And one of the ways to prevent that is going into collateral vessels, coiling things off. None of that was necessary here. Again, there are a lot of operators that, and sometimes with us, even if we were doing particles in the past, would have gone there, seen the collateral, coiled it off, and then had to do the primary embolization. And, just another demonstration with glue about how it's a one-shot deal with the control that you have, and it's incredibly fast. There's a really nice example.
I think, guys, I think it's a perfect segue to kind of talk about the rates of recurrence, and what data we have, and obviously we're not there yet in terms of data for recurrence after glue embolization, but maybe you can kind of speak to what we know so far.
So that's a good point. I'll just if you guys read radiology, and some people do, Carnevale a couple years ago presented his 10-year data, and if you look in detail at that study at 6 years, there was a 23% recurrence rate at around 72 months. And so that's that's high. I think we can do better than that as a procedure that is still sort of in its, I wouldn't say infancy, but we don't know everything about PAE yet. That's a great, there's a lot of room for improvement in terms of recurrence. I think we're in the external.
Yeah,
Let's just
we're in external.
go back and just do a run. Yeah, we'll pull back a little higher. It's right there.
Okay.
Just grab that glide wire.
Yeah,
Puneet.
got it.
It's in there. Yeah, so look, if we can do better than 23% with glue, we won't know until we're about 5 years out what the real recurrence rate is, because like I said, the majority of the recurrences, when we see recurrence at its highest rate is typically years later. So we've only really been using glue for close to 2 years now. And so we're presenting we presented our data last year at FSIR. We have a paper coming out with some of our results, but we don't have 5-year data yet to look at the recurrence rate, which obviously is going to be super important to ultimately look at.
For a period, you were, coiling the prostate artery on the way out. Do you think that's really where the failure is, or are these recurrences, taking place because of this collateral supply that may be
I think
going
it's
on?
both, Vivian. Honestly, the cases that, let's just put up that run as a roadmap. The cases that I've done and I've repeated, and we've all done repeat PAEs. If you see these patients, regularly, you realize that years later they start to get recurrent symptoms. They don't always get back to where they were baseline, but when you bring them back and you do these angios, what's interesting is that sometimes if you just use particles, it looks like nothing was even done.
Mhm.
That's sort of the one of the interesting things about particles is that they don't really cause permanent vessel occlusion in a lot of the cases. And that's not necessarily a bad thing in some vascular beds, but I think in the prostate, you want a more permanent occlusion. I think it's advantageous. And so you bring them back and it almost looks like nothing was done. I've had some cases where we've coiled them and the coils haven't even occluded the vessel completely, and you see flow through the coil mass. And so there's lots of reasons why people would recur. It's probably about half and half, where it's through the main prostate versus only through collaterals. And sometimes it's both. You see the collaterals hypertrophied, but you also see the main prostate still supplying it.
How long are you seeing these patients in clinic after a PAE?
So I usually see them at 6 weeks after embolization to get their initial response. And we don't really want to see them at sooner than that, because the first 2 weeks, they're generally not great. They're usually worse. When they come into the office, I do, obviously we do their IPSS again. And then we do in-office uroflow, as well as a PVR If they're catheter dependent, I'll see them sooner, but that's really the only case where I'll see them at 2 weeks or maybe 4 weeks, because we want to do a trial avoid. And we do that typically in the office 2 to 4 weeks after the embolization. But if they don't have a catheter, we usually wait 6 weeks, and we could do a full assessment in the office. And then after the 6-week visit, we'll see them back again at 6 months. And at that point, we try to do a volume assessment of their prostate. The best way to do that, in my view, is to do an MRI. And so I do an MRI at 6 months. Can you guys zoom in on?
Can I get that smart mask?
Go ahead. If you guys want to zoom in on this wire, if you switch cameras, zoom in on this wire.
Your post-treatment MRI, have you compared the rates of ischemia or infarction using a liquid versus your prior?
We haven't compared them, Vivian, but we do see a fair amount of necrosis, particularly if you can get very distal. And so I think in this patient, almost certainly we're going to see some necrotic areas in the prostate. Can you guys see the shape of this wire here?
Yeah.
Let's see. Yeah. So everybody that works with me knows that this is my favorite shape. It's not as dramatic as I guess it sometimes is, but I call this the question mark. And I think for prostate embolization, giving a little back curve on the wire along with the tip curve gives us the best chance, specifically if you're not using an angled microcatheter, to get into those really angulated type 1 vessels. And so that's the curve that we use. And this is an 016 wire. So we have a little weird angulation here in that internal iliac. So Dan's working on that now. Now we were talking a little bit about follow-up. I do all the follow-ups myself, and I will only really refer them back to the urologist if they needed a cystoscopy or urodynamic. Everything else we manage ourselves in our clinic. We see the patients obviously pre and post. I manage their medications. I'll start their medications. I'll take them off medications. And I think anybody that wants to do prostate embolization, in high volume, really needs to become familiar with how to manage these medications, because almost everybody is either on them or has tried them. And so, a lot of patients have side effects from them, and you need to be able to manage that.
Do you want to talk about what you're doing pre in terms of uroflow, post-void residuals? Like, what do you think is the minimum that you should be? Is there a minimum?
Yeah, I mean, the minimum, I think you need to get a flow rate. You need a Qmax in anybody that you're trying to show that they're really obstructed. I don't think you need a urodynamics in everybody, but you definitely should get a uroflow and a PVR, which is super easy to do, especially, in your office where you probably already have ultrasound. We're going to pull back a little bit because we're in the glute here, but we're going to set up for another run.
Yeah, I mean, I think the low-hanging fruit, when somebody's watching this and they say, all right, I want to start doing more on the spectrum of urodynamics, you don't need full urodynamics, but again, the post-void residual and the uroflow, they're not expensive, they're easy to do, and it provides you with, I think, the two most important pieces of information as a baseline.
Yeah, and to be able to do that yourself in the office without having to go see a urologist.
Exactly.
Particularly if they don't necessarily need a urologist for this. And so if you really want to do PA, I think at high volume, you really need to be an expert in BPH. And to do that, you have to be able to take care of them clinically.
We have one.
All right, so we're going to hook up the injector here. And we're going to do another injection in this internal on the other side. And again, we're at 16 minutes. That was actually the longest part of the case there, is getting into the internal.
The crux of the case right there.
Aaron, we have a question in the chat. Do you ever still coil out?
Well, that's a great question because we don't need to with glue. And you saw what we did on that last bit of glue. We sort of put almost like a little plug at the top after we got that distal. And so I try to occlude the parent vessel just with the liquid, so you don't need coils. You can use them, but there's no need because you have so much embolic here that you can use to form a plug. So no, the answer is no, Jay. All right, so we're going to do another angio here.
Aaron, can you talk about like the retreatment, the ones you have done? What have you seen? Is it more collaterals? Is it more from the main? Is it different when you've seen particles versus glue?
Yeah. It's usually, we pulled back too much on that, unfortunately. Sometimes we try to get a little greedy and we pull back because we want to see the SVA origin, but this origin's a little too steep. Let me see if I can just puff it back in there. We're gonna ask Dan to do that again.
I mean, again, crux of the case right
But
there.
it's probably about half and half, right?
Yeah.
And that's really what it is. Half the time it's through collaterals and half the time it's through the main parent vessel. I have not seen recanalization through the main prostate artery with glue. You absolutely can see collaterals if you don't occlude them, but the main vessel does not remain patent, and the branches that you've embolized do not remain patent. It's about half and half, but I haven't repeated a lot of glue patients. I think only one, and that patient, I believe.
Debbie, I'll take a smart mask.
If I remember correctly, had a vessel that we missed initially. So it wasn't that the glue failed; it was just that we didn't locate the collateral, which I believe was off the umbilical artery, if I remember correctly.
Well, I mean, even just looking at that glue cast, right? Looking at that embolization, that's quite a vessel to recanalize that entire way.
Yeah.
Right? That's not. We're not dropping a small glue plug. We're not just going distally with a few millimeters.
There's so many studies that have looked at the effect of glue on the artery, and it really creates a fair amount of vascular endothelial damage and inflammation, and so we want to use that to our advantage. And that's one of the best properties about glue, in my view. You want something that can do that. Yep, there we go. That's not my favorite origin in the world, but it'll be okay.
Well, I'm
You
using
guys
the
hear
other
me?
side as using the other side to help me guide where it's coming from on this side. But is it coming off the
So
pudendal right there?
It's looking
Looks
like a
it's
one here. Yeah.
Yeah, type 1.
It looks all right. So yeah. So on everything you want to identify the posterior division, you want to see the big C-shaped vessel, which is it's drawing now. It's going to be this big C-shaped arm. And again, we're doing this at a 35 to 45 ipsi oblique with a tank radial. And then the vessel over here, this is the upside down Y, the distal bifurcation. That's going to be your obturator. That's the vessel that was missing on the contralateral side. So kind of at a starting point, and again, coming out, this isn't the anatomy that we're all by default very familiar with unless you're doing these types of cases. Start off looking, again, here's your obturator, here's your internal pudendal. You want to be kind of looking in the middle for an S-shaped vessel, and that most of the time is going to be your prostate artery. And as you're looking in that area, we're seeing it right here. So we talk about different, origin types. I think Aaron is very, very excited in particular. My general thoughts are, that's great. Let's just find it and get into it. But, it's important to classify.
What was the other side? Was it pudendal or gluteal?
I think it was off with gluteal. It was a 5.
It was
Gluteal.
I have
glue.
to go back and look.
top 5.
It was glue.
So it was a 5. The 1 is going to be the shared origin. It's most common, again, percentage-wise. For Aaron's case, we'll get into it. 30%, I believe, the most recent data are going to be the type 1.
So we actually looked at this, and we're going to present this at
Type
SIR.
1, the
Okay, so I
most-
don't want to spoil it.
Well, no,
So-
they're about equal, all of
Yeah.
them. It depends on what
Well,
you
a
look
1 and
at.
a 4 is probably. See, this is
4.
the problem when we get into the.
4 is
Exactly.
probably the most common.
I'm in Dan's camp.
But
as well.
can we roadmap that?
Yeah.
Put the thing in the thing.
Look, we all need to get published. We're going to have a 1A, 1B, 1C classification at some point. It's coming down the road. But the 1s can be challenging. And again, I think that kind of comes back to what we were talking about with microcatheter selection. Using like an angle true select or something like that. If you really have a challenging origin, especially starting out, use what you're comfortable with. And if it's really going to be a tough situation, and again, that true select, it's a 2 French, it's a 2.8 to 2, and especially in tall patients, you're going to get 175 length out of it. But it's really what you're most comfortable with. The sniper obviously tracks really well, as we saw in the other one with a type 5. But I think a lot of
Bring it
people
back. You have a
consider the
curve on
type
this, so
1s
we
to
can
be
probably
most
use the
challenging to get
curve.
into. So, I mean, I can't
You
anticipate
guys
there's
are
going to be a problem
working
here.
with the true select
you know.
here, or are you with a sniper right now?
Yeah,
Sorry, I missed that.
so we switched, and so I was actually
Yeah.
that might be it. Is that it? Keep going.
Yeah.
That might be it. Yeah,
I thought it was.
maybe not.
No.
Oh
No,
yeah,
I thought it was a more.
that's the Brecktal.
Lateral.
Okay,
More
Yeah.
posterior one.
Well,
yeah.
do you want to shoot it?
more posterior. We can
Yeah.
shoot it just
We
to
can
shape,
shoot
but
it.
that's going to
Good
be
to
rectal
check.
because it's posterior to the
Yeah.
to the prostate. So type 1 takes the longest. We actually looked at this. We looked at our fluoro times and procedure times, and type 1 takes longer than any other type. So not surprised. And so when we have a type 1 with a sharp angulation like this, I don't love the sniper because it's stiff. So what I like to use is something really soft with an angled tip. And so this is a True Select 155 with a burn tip. And so this, I think, will give us the ability to curve and then make a quick turn to that prostate. But before we do that, we are going to do one thing and just inject this vessel posteriorly. And so when we see two vessels that look like the prostate, the one that's posterior is usually the rectal. They both have an S shape, but we'll see. It could also
This
be
is
just
an
the back
awesome
of the
case.
prostate.
Oh,
No.
no, that looks
It's
rectal.
That's
Yep.
definitely rectal. I
Yep.
don't think you need
Yeah.
a cone beam CT for that.
No.
What do you guys
Yeah.
think?
The other
There
thing
actually
you
might
can
be a little
do,
prostate off of there at the
Yeah.
bottom.
maybe a little bit, but that sort of very straight medial going branch is fairly rectal
Yeah.
characteristic, right?
And you have
And the other
glue on the
option
other
that you
side.
have, what
Sure.
Aaron was saying, the poor man's, you want to puff back? So we said.
Well, it's probably better, I think, to go steeper, and then we'll
Yeah.
take a better look zoomed in. I think we're gonna do another run because it's, especially for everybody that's watching, I think people want to see the origin in better detail. So let's see if we can open it a little.
The one origin, obviously the steeper is going to really show you
Yeah, I'm gonna go real steep here, 50.
that more anterior side of the anterior division and open it up. We probably have
Yeah, and so
5 or 10
this
minutes
is where the
here
angled catheter. Yeah,
just
we
to
have
keep
5
you
minutes to do
guys.
this.
Yeah, 5 minutes.
You can see it there.
Yeah.
All right, let's go. Vivian's giving us a challenge here.
Mhm.
What's the curve look like? That looks pretty good. Pull the wire back. We could also try a different catheter. The angle on this is good, but it's a burn tip. I sometimes like a swan tip, which is only really available in the direction, not the True Select. And the direction's a bigger catheter, which I don't love. So we'll try with this for a few minutes.
Did you change the shape on your wire to make it more
We
aggressive?
made it a little more curvy. Yeah. The other problem, and this is why these are always hard, is that the base catheter doesn't have that much of a curve on it. Oh,
There
hold
you
on a
go.
sec. So Puneet's going to spin the wire and sort of see if it just flies down there as he pushes. Or I can just track it and go in there. Hey, you know what? Let me follow you. Put a little back tension on that so I can follow you in a sec.
Because you gave
One
him
thing about that True Select, it's
There it is.
so
Look at that.
Nice.
trackable. You don't necessarily need that much wire
Nice.
ahead of you but that's awesome.
Yeah, it's because she said
I
5
said
minutes.
Alright,
5
see if you
minutes.
can get a little
and
more
did it
wire.
in,
Yeah.
1.
Just needed a little.
That's great.
Yeah, so there's your loop, right? You know you're in the prostate when you see a loop like that. And I'm not even really, I'm just sort of sliding it. You guys can see it's with one
Yeah.
hand. It doesn't really require a lot of effort with the True Select. So we love the True Select for that reason. Again, I like the Sniper, but I don't like it for that origin because ultimately it's going to be a little too stiff and it might create an issue. But you guys will see in a few minutes, there's a big difference in how you inject an end-hole catheter with glue than a balloon tip catheter. And so we're much less deep oblique here. We're going to do a run, then we're going to do nitro. You good?
I was going to mag out a little bit.
I like it.
When you're not using balloon occlusion, do you try to get the base catheter even closer to sort of provide a little bit of a
Interesting.
Yeah.
So-
occlusive
Let's
injection?
keep going.
Yeah.
Further. We could do a little nitro first. Say that again, Viv.
Oh, I was just saying, if you're not using a balloon occlusion catheter, do you ever try to
Yeah.
drive your base catheter in to provide a little bit of
Yes.
occlusive?
We can do that. We can do that, but I think in this example,
Yeah.
we're not going to get it that close. Right? But I think what you're getting at is we can do the wrap mill later. Let's grab the wire and we'll just go around that bend. We have a little bladder branch there approximately. We're just going to get past that, and then we're going to go down, drop some nitro and verapamil, and then we'll embolize, and we'll be done in 5 minutes, like you asked, Viv.
Thank you.
Not bad. So one of the things I noticed when I looked at that angio very quickly was that the bottom part of the prostate is not filling on that angio. So most likely that's that piece that we saw off the rectal.
Yeah.
Which everybody noticed that there was something. That's the
That looks like the superior
Water,
branch.
yeah.
Yeah.
Let's bring this back a little. The roadmap's not going to be accurate anymore. But that little piece at the bottom of the prostate, which we see on that image there, that might be it, right?
Yeah.
Let's track and see what that is.
No.
I don't know.
Well, let's see. We'll do a puff.
Let's take a look. is probably going to be fed off that rectal very distal. And so I'm going to probably ignore that. I mean, we could do a cone beam CT to prove it, but I know based on the angiographic appearance, that little piece of the prostate is probably fed off the rectal. I don't know that we have to chase that because we're probably going to have to embolize a fair amount of the rectal branches to do that. But if it was a solitary vessel, I would probably say that looks pretty good.
Yeah.
Why don't we keep?
We're still going into
Why don't we
there.
keep
I think
going?
we should go a little bit more distal. Yeah.
So the difference with a balloon and an end hole, and we talked about this before, Viv, we want to go more distal without the balloon because we're not going to be able to penetrate as deeply without the balloon. And so one of the tricks is to take the base catheter and proximally almost try to create spasm in the proximal prostate artery with that catheter, so you almost create your own balloon occlusion.
Do you want to pull back the catheter a little
Yeah,
bit?
a little
I don't know,
Might be a
Aaron. I
little
think
over
you
for me.
could, once you get the wire in, you may be able to advance your base catheter sort of into the.
Maybe.
You can give it a shot.
Yeah, we'll give it a shot. Maybe. We don't want to get greedy. We got to make a turn here. That's the challenge on this one. You know what? Grab Debbie. Grab the Asahi wire. If we can show that one. That I like for these turns.
We don't need a better curve on this.
You can also just do a better roadmap because that roadmap doesn't look very accurate anymore.
I think it's important that we kind of show the glue and the difference between both, the two sides.
Yeah, we're going to show it.
Yeah.
And
if
then
we're able to, time allowing.
let's see that. Let's put that up as a roadmap, Debbie. We have a different wire, which sometimes works a little bit better than the Fathom for these sharp turns. So we'll see if this works. This is an 016 180 centimeter Asahi Meister wire. So the nice thing about this is that we can make the tip very, very sharp. So it's a little softer on the tip. I like this a lot for these vessels.
Also compared to the Fathom, I think it holds the shape a little bit better.
Yeah, that'll work. Let's try that. And then we'll be done in a few minutes. The other thing is if you can't get the wire into the microcatheter, then you know the tip is really good. So let's use a cheater for that. Sorry for taking so long, Viv. I apologize.
Well, I think it's a nice example, when we were getting into that,
Do you guys see what I was talking about? The bottom part of the prostate's missing.
Yeah.
Now, if you had a balloon, you could theoretically fill those branches by using the intraprostatic circulation to try to send some of that embolic
Pressurize it.
lower,
Mm-hmm.
pressurize it. With an end hole, you typically can't do that.
Yeah. At what point are you
You guys-
trying to go after those branches? I mean, like you said, if it's coming off of the rectal, it may not be feasible.
It's not that we couldn't do it. It's just I don't know that we're going to, the risk is that we get a fair amount of non-target rectal ischemia if we really get distal into that spot. And so I'm going to say today no, but if he doesn't get the best response in the world, we could consider it. But I think given that we see the majority of the prostate hopefully being treated after this injection, we'll probably just see how he does, and we have to bring him back to do that. In my experience, that's not going to be a significant contributor to his symptoms. Again, he's got severe IPP. Look at that, went right in. So, that's why I like this wire is because it has a little bit of a better curve on the tip. We'll probably go a little bit further if we can. That's a small branch. Probably just
come back a little with the camera.
You don't really want to be too greedy with some of this stuff because sometimes when you get really distal, you miss certain branches. I don't think that's the case here, but
Let's some nitro.
See that sharp turn?
But I think this is a nice demonstration. Again, getting into the type 1, making these maneuvers inside, getting a little bit deeper. People talk about a lack of torqueability from Radial. I mean, I think this is a nice demonstration of all the things that you can do. Again, it's about the tools in your toolbox. This might have been challenging with a different microcatheter, but with this type of microcatheter that will track so well, we can get into any of these types of vessels.
Yeah, the True Select has really been a game changer for prostate, I think. Especially the angled tip. And, some people have their opinions about angled tips, but I really like it for this. It actually may be hurting us here.
Here's some sand.
How much
that
nitro and
Saline.
verapamil do you usually
We
give
gave
in these
a lot.
direct installations into the
Usually every time we inject, it's about 200 and 2.5 verapamil. So I usually have at least 1,000 ready and about 10 of verapamil. Let's see if we like our spot here. That looks pretty good,
Looks
guys.
pretty good. Let's do what you say.
Yeah.
All right. See, we're missing that spot at the bottom, but that's okay.
Nice.
We're going to do A little bit more nitro here. All right, let's grab the embolic, Puneet, and we'll get going. And then the other nice thing about radial access is he can go home basically in an hour. We'll have him pee, we'll take the band off, and he'll go right home.
Did you talk
Puneet, you
about
want to talk about what we send the
on?
patients home with? Yeah.
Yeah.
Yeah, so we sent him home on a week of antibiotics, and we also prescribe a Medrol dose pack to help reduce some of the inflammation that we're gonna elicit in this prostate. Additionally, sometimes we'll send him home on some symptomatic control medications like Mobic or Iridium. Pretty much it. No pain medications, just Tylenol.
Beautiful.
Yeah. I mean, a lot of, this is obviously the majority of his prostate in the middle lobe here. So we're gonna show you how we do this differently without the balloon. So let's do that now.
So this is D5.
We're going to do D5 first. And so the technique is a little bit faster. You can see there's a collateral going to the other side of the prostate too, which is nice. So this is always the challenge, how to get it distal without refluxing it, especially when you have a small vessel. We do have a long runway here, so we can go pretty fast. I'm not worried about any collaterals at the bottom of the prostate going to the penis. So we're going to inject very fast here. And so Puneet's going to focus on that. I'm going to focus on looking at the catheter, making sure everything looks good on that side. Okay, here we go.
Injecting.
You already
Came back a little bit there. So stop.
Yeah, you get a little bit of reflux there.
Okay. So that's it. I'm going to take you can fluoro save that, Debbie. You got it? Look at the difference, right?
So yeah, it shows a huge difference when you have the balloon occlusion and when you don't.
I pulled it out. Don't worry. So
with it out, some of that may
I don't know if you
end
guys
up
saw.
percolating forward a little bit just because of how thin your dilution is, but it's obviously a very big difference.
But we have a complete occlusion of the prostate artery here, which is nice. I'm just going to rotate a little bit so you guys can see. But the middle lobe is well treated. And we're probably going to get a few areas of necrosis on the MRI in 6 months. But I'm really happy with this result. Are you guys happy? Great.
Yeah.
We're going to do a final run. We have another vessel there? What do you guys think of that branch off the pudendal? Actually, no, it looks like rectal. See that?
Yeah, no, I think you're done here.
Yeah, it's rectal.
Are there any burning questions, anything on the chat that you think we should really try to address? Or
I mean, there's always
any burning questions that you guys have?
Getting catheters stuck, but I think, the thin dilution, that's not really a concern.
Yeah, I haven't had that be an issue. What's more common with the thin dilution is that the glue actually travels too far up because it's so loose, and so you could theoretically get, if you're not careful, a lot of reflux, and it doesn't necessarily solidify until it's close to the base catheter, and then that's where you got to be careful because you don't want glue in your base catheter, obviously.
I think this was a fantastic.
Yeah,
it's a great case.
All right, if there's no other burning questions, I think that'll just be it.
All right, guys. Well, this was really awesome to start off our Treat Live symposium. We're going to have another case in a month. And we're going to also put this case up on YouTube at some point in a small edited format so everybody can rewatch it. And really looking forward to seeing everybody at FSIR.
Great. Thanks, guys. Appreciate it.